today is creating the systems that support breastfeeding. I'm also extending welcome from Emma Seeger, who's running our platform, and the National Breastfeeding Week working group that have worked so hard to get lovely speakers for you today. Just before we get started, while people are still popping in, I'd like to invite you all to pop your land acknowledgement into the chat if you would like to do that, and also to let you know to put your questions and comments into the chat, and we will take those and address them at the end of the session today. So I'd like to acknowledge that the land that I live on is part of the treaty lands and territory of the Mississaugas of the Credit First Nation, and I recognize the traditional territory of the Huron-Wendat, Haudenosaunee people, and acknowledge the First Nations, Inuit, and Métis people who live on these lands today. Alrighty, let's get started because we have a nice full program today. And I'd like to bring you greetings today from Mike Schreiner from the Green Party. And the reason why we invited him to give us a little opening welcome was because the Green Party actually mentions the Baby Friendly Initiative in their political platform. So let us hear from Mike Schreiner. Maybe. There we go. There we are. Thank you to Mike. Whoops, what's happening? So sorry about that. Sometimes we press the wrong buttons with Teams. All right, so our very first speaker today is Lauren Columbus, and she is the academic practice lead with the Department of Midwifery and Registered Midwife with the TIME program, the expanded midwifery model at London Health Sciences Centre. She's also an adjunct clinical professor in the Department of Family Medicine at the Schulich School of Medicine and Dentistry. She holds a master's in health professions education from Maastricht University. Her areas of research and academic interest include collaborative models of perinatal care delivery, team dynamics in birthing units, quality assurance and quality improvement, and simulation. The title of Lauren's talk today is Implementing a Collaborative Midwifery Maternal Fetal Medicine Care Model for Improved Postpartum Care. Over to you, Lauren.
Thank you so much. I appreciate the introduction. And I just want to thank the Breastfeeding Committee of Canada for inviting me to join this amazing group of presenters for National Breastfeeding Week. I am presenting on behalf of my wonderful tiny team of midwives who work in the TIME program at London Health Sciences Centre. And I'm excited to share what the implementation of this type of program means for high-risk pregnant and postpartum populations, and what it can look like when it comes to addressing infant feeding and breastfeeding rates. I also always mention that these types of, tiny programs are sort of the essence of this year's theme of creating sustainable systems that support breastfeeding. And sometimes we get really overwhelmed at the thought of like, how do we change a system that in many ways can feel very broken and, we know could be better. But it feels overwhelming when we look at it from, either a citywide, a hospital-wide, a provincial, or a national level. But, I'm all about these kind of small little programs that work at the edges of big problems. So that's what I'm going to share with you today. I feel very fortunate to present on this topic because of how neglected I feel in general that our high-risk pregnant populations, or those who experience complex pregnancies, are when it comes to postpartum care in general. I think, there's been lots of articles published about the way that our healthcare systems fall short for postpartum care, but particularly for those who had medical complications or fetal complications in their pregnancy. Within that subset of postpartum care, I especially feel that high-risk people get the short end of the stick when it comes to the way that they're supported, and also just in the general knowledge that exists on their experiences of infant feeding. We know that pregnant people who experience medically complex pregnancies have different needs and supports and considerations that have to go into their infant feeding plans. And it doesn't always feel that the structure of our current sort of perinatal care model supports that particularly well. So the learning objectives for today will be to explore what these needs are for the high-risk parent-infant dyads, and what the effect is on infant feeding. And I'm also going to really talk about the impact that our program has had on, and this type of collaborative midwifery postpartum care model has had on our high-risk populations here at London Health Sciences Centre. So I'll start out with some quick Gohl's notes on what the TIME program is. So we're a small program based out of LHSC, and that is a tertiary care center in Ontario. So we do have a high-risk maternal fetal medicine unit, and that is with whom we collaborate. We are 4 midwives, and we provide collaborative antenatal care with MFM and education. We reach about 170 high-risk pregnant people and their infants every year. So it's about 10% of the MFM population here at LHSC. They see about 1,800 people in their program. And so it sort of feels a little bit like, just scratching the surface. But again, you have to start somewhere. We're funded by the Ontario Ministry of Health's expanded midwifery care model funding. For those in Ontario, you're probably well familiar with this type of funding. For those from other provinces, it might sound like a bit of a mouthful, but effectively it's a way of funding midwives to work outside of what we consider to be sort of traditional billable care models, where, a midwife takes someone into care, provides the full spectrum of care, and then bills afterwards. This is a way to create some different types of systems that address unique populations with perhaps high needs. So I believe you heard from an EMCM midwife yesterday, potentially with the CAMP program in Guelph. And so there's probably, I would guess, around 20 similar programs that are funded in Ontario. Our criteria for referral to our program includes a variety of social and medical indications, things like a history of mental health diagnoses, newcomers to Canada, individuals who are experiencing poverty or unstable housing. Bereavement is a big part of our work as well, either in the current pregnancy or in a previous pregnancy. And also just individuals with generally complex care plans that might really benefit from very close ongoing community-based follow-up after they're discharged from the hospital. We have since added free prenatal classes that are targeted specifically to high-risk pregnancies. We offer a prenatal class as well as infant feeding and newborn 101, and we also do a course on multiples and if you're expecting an ICU admission. So those started about a year ago. And our program provides lots of access to different supplies, and particularly, we have a whole library of books and workbooks for mental health concerns, but we provide a ton of materials at no cost for some of those typical breastfeeding things like pumps, pump kits, nipple ointment, shields, that sort of thing. And we run a very strong donation cycle bank as well for lots of baby items. We launched exactly 3 years ago. And as I said, we added our prenatal education model in person and online modules as well about a year ago. At the end of our second year, we launched a formal evaluation of the program's reach and outcomes and collected clinical data for everyone who had been enrolled in the program for those first 2 years. We were doing this both from, quality assurance perspective, just to make sure we were meeting the target demographic that we'd set out to meet. But we also wanted to know, what kind of outcomes does this population have? It's not particularly well studied, and we wanted to contribute to that literature. So all of the data I'm going to show today come from a very dedicated group of researchers who hand-pulled every piece of information from our patients' charts so that we could have this very sort of fulsome view of who we were serving. I did mention, that we provide this collaborative form of care. So what that looks like is, in general, at least from our study, we provided on average about 4 to 5 prenatal visits antenatally when they were here to see their MFMs, as well as any prenatal classes that people attend. We focus on preparing for the birth. We focus on infant feeding and the transition home after discharge, especially for those who have medical complexities and will need sort of ongoing follow-up. We focus a lot on mental health and for our populations who have mental health concerns in how to cope with that in the postpartum. We also attend cesarean sections that are booked, and we do immediate skin-to-skin contact in the OR and assist with infant feeding, but otherwise we don't attend births. So that makes us a little bit different than a typical midwifery model of care. We do the usual types of postpartum visits that are very common, at least in the Ontario model of midwifery care. It's entirely home-based for about 6 to 7 weeks postpartum. We usually see them day 1 in hospital and start some discharge planning. And then we do about roughly 8 postpartum visits at home after that throughout those 6 weeks. Sort of every other day for those needing that sort of frequent and early home-based support for infant feeding, jaundice follow-up, and following up on how the birthing person's doing. For anyone who has infants admitted in the NICU, or if they're staying at Ronald McDonald House while their infants are there, we'll do those visits where they are. So if they're in the NICU, we do them there. If they're at RMH, we do them there. In terms of sort of the focus of this talk, which is around high-risk populations and breastfeeding, I was really humbled when I started to work with this population, and I moved from working with a traditionally low-risk midwifery population to this high-risk population. And prior to starting, I had looked up my BORN, which is our Ontario perinatal database of pregnancy and postpartum outcomes, to see what my breastfeeding rates had been for my patient population while I'd been practicing as a midwife. And I was almost at 90% exclusive breastfeeding rate at 6 weeks. And I was very proud of this. And I kind of naively assumed that I might be able to bring this type of success, into the high risk population just by virtue of our model of care. Like, surely just, having midwives, having the prenatal education, and then 6 weeks of postpartum care will be the thing that can solve this issue. And, I was humbled pretty quickly within my first year of practice in this program, and realized, for a large variety of reasons, people who come into our program or who have high-risk pregnancies have some different goals that they have around infant feeding in the first place, but they also just have very different lived realities that impact the way that breastfeeding might go. And so one of the first things that I realized immediately was that most of our patients are not eligible for early discharge the way that I'd typically practice as a midwife, which was home births or direct discharge from the birthing unit. And many of our patients have to stay over 1 to 2 days, sometimes 3 to 4 postpartum. And they had about a 30% exclusive breastfeeding rate on day 1. which was a very tough pill for us to swallow as a team. And our overall breastfeeding rate at LHSC, exclusive breastfeeding rate on discharge on day one postpartum, was actually 53%. So it wasn't particularly high for the whole general population. Low risk, high risk, midwifery births would have been included in that. So within our population specifically, those who had been referred to time, we were at 30%. And so it really became a job or a role for us to really kind of claw back that breastfeeding rate over the subsequent 6 weeks, which was generally sort of the opposite as it usually goes with infant feeding. So this list here that I have on this slide sort of represents a summary of the factors that impacted those in our program, and people experiencing high-risk pregnancies in general. But one of the biggest sort of factors would be the first few on this list, which is just that there was a very limited immediate skin-to-skin or golden hour or sort of feeding initiated within the first hour in this population. And when we really dug into it, significantly, this was based on separations, mostly medically required in terms of NICU admissions, or complicated cesareans with an unstable birthing person, multiples with prematurity who were admitted. So many of those factored into just no kind of immediate skin to skin and very prolonged separations. And that was probably one of the biggest factors. But the hypoglycemia protocols, and this may vary across the country. I'm not super familiar with how other provinces or cities do this, but our hypoglycemia protocols for infants apply to those with diabetes, on beta blockers, any preterms or low birth weight infants. And so this affected a significant number of people in our program and really led to early initiation of formula. Cost obviously was a big factor, and mental health, in particular, anxiety, really played into the ability to sort of trust the process that we often ask people to engage with infant feeding. And this is really particularly prominent in our bereavement populations, which we'll talk about in a bit. But when we sort of look at a description of our own population here in time from our evaluation, we had nearly 40% of our patients who were receiving income assistance. About 39% belonged to a racialized minority. Our London baseline population was about 29%. So it felt like we were at least, meeting the target of accessing mostly our newcomer population. We had about a 10% disclosure rate for intimate partner violence and about a 12% rate for bereavement cases. And so I would say that many of these factors, played into people's goal setting and their sort of ability to focus on infant feeding as a priority in the postpartum. Obviously, when people are on income assistance, or sometimes they're not even able to access government forms of income assistance, living in extreme poverty or with extremely unstable housing becomes top of mind with a newborn, and it leaves very little bandwidth to focus on anything else other than just eating and surviving. And that was a very big factor for many, many people in our program. In terms of our mental health concerns, this is a referral criteria, and it's one that is pretty significant and important to referral to our program. So for our first 2 years, we had roughly a 67% baseline rate for mental health concerns, either a previous diagnosis or a current new diagnosis in pregnancy. So this was a place where things were quite significantly different from baseline populations. So using some of the CanMat data that from the guidelines that were published this past year, we had, roughly double the rates of anxiety diagnoses and quite significantly higher rates of depression diagnoses. But We had many other types of mental health concerns as well. We had a lot of post-traumatic stress disorder related to experiences of violence or of healthcare trauma with previous bereavement or losses. And we also had several conditions as well that were very like sleep dependent conditions, or they were taking types of medications that they'd sort of always been told were not compatible with breastfeeding. And they've internalized these messages for a long time. And so one of the things that we do have access to at LHSC is a clinic which is run by a pediatric clinical pharmacologist here who does counseling for the impact of medications in breastfeeding and during pregnancy. And so that's fortunate to have that expert and that expertise available to our clients, because their use of medications for not just mental health concerns, but medical conditions in general is very high. And they are often incorrectly told all along, you know, this is not safe in pregnancy and this is not safe in the postpartum. So the number of people who stop all of their mental health medications cold turkey the minute they find out they're pregnant is very high. And also just the number of people with previous medical conditions for which they are taking a variety of medications who just off the bat are feeling like, well, breastfeeding is not a possibility for me, is also very high in our population. So there's some education that has to happen in conjunction with our medication safety colleagues around kind of reaching that true informed choice place where they're not just being given kind of erroneous information about medication safety. When we looked at some of our birth outcomes and sort of how these might play into the way that infants are fed and decisions that parents make and goals that they have around feeding, we also had a very high NICU admission rate that was about 23%, and just about 1 in 5 of our births are preterm as well, with about another quarter being low birth weight. We have a 40% cesarean section rate and a decent number of multiples as well in our program. And so just some of these factors alone really influence breastfeeding rates in a way that cannot be overstated. There's a lot of lack of expertise around how to feed premature infants who have been separated from their parents, and low birth weight infants. And I feel like it's probably a cultural piece in different NICUs based on what type of experience they have access to. But this was one of the biggest barriers, was just that most parents did not feel supported in any type of breastfeeding in our NICU, and in particular with sort of early preterms, or even some of our kind of late preterm populations, which is certainly an area that our hospital has a lot of work to do. The hypoglycemia protocol, as I mentioned, really impacted a lot of formula initiation for our population. And there's sort of an approach where, well, if the infant doesn't have a good feed in the first 2 hours, we know the sugar is going to be low. So either have a good breastfeed, which may or may not be possible depending on the situation of the birth, or we're giving formula. So it's often initiated within the first 2 hours of birth, which becomes really, really challenging to sort of address in the coming days and weeks. So to that idea, in terms of this very early formula initiation in this population, one of the most important findings from our program was that exclusive breastfeeding rates started out lower in the hospital and actually increased in our program across the next 6 weeks. And this is the sort of exact opposite of what happens with the general Canadian population, as well as with our London population too, between the 0 and 6 week marks. So as I said before, there's a lot of effort that goes into those 6 weeks to sort of claw back to exclusive breastfeeding rates for those who had that set as a goal. And the impact for those first 1 to 2 days in hospital is really challenging on being able to ultimately achieve the rates of breastfeeding that our population wants to have. So we have some numbers broken down here, but you can see that sort of for all infants, our exclusive breastfeeding rate at 6 weeks is about 50%, but on day one we're sitting in the 30s, in the 30%, and that differs. Of course, you can see our preterms; it's significantly lower, obviously, versus our term infants. In the next slide, this is the data from the Government of Canada's breastfeeding dashboard, which I think was updated as of last year. But generally speaking, there's quite a significant decline from day one exclusive breastfeeding rates to 6 weeks. And in particular, as they say here in the slide, it's particularly in that first month. And we know that having home-based, care, access to people with good lactation support training can sort of help buffer that really steep decline in the first month. And in our case, actually sort of reverse the pattern completely. So the Canadian data for 6 weeks is that, it's roughly about a 70% exclusive breastfeeding rate for the general population. But for our London population, I don't have a 6-week rate, but we do have a 53% exclusive rate at birth and 34% at 6 months. So in terms of sort of some of the key takeaways from our experiences working with this population, the impact that social determinants of health will have on breastfeeding are very significant, but they're not particularly well addressed in our hospital and community support systems that we have. So as I said, there's a significant lack of expertise around addressing ways that people can manage to breastfeed when they have low income or unstable housing, or are single parents, newcomers to Canada, not a lot of information or programs available in alternative languages. Those are real gaps that we've seen with this population. But also the goal setting, as we talked about at the beginning, can be really different for people who are experiencing sort of a disproportionate impact of the social determinants of health on the way that they move through life. And so goals can often be there's sort of an elephant in the room around breastfeeding, in that we know that our populations who are on income support or are struggling financially, if they aren't breastfeeding, they have a really hard time accessing formula, and the cost of formula being what it is. And so the elephant in the room being, well, if you don't breastfeed, how are you going to afford a long-term commitment to formula, is a really sad reality of the discussions that we have to have with people. And it feels like a little bit of a coercive way to focus on infant feeding and to frame infant feeding. So it's not something we like to address, but we also know we've had many people struggle to afford formula or access it in the way that they need to, and have seen a lot of really difficult situations around that. So that's something to think about. And the medication safety clinics, as I mentioned, are really, to me, very necessary and essential to support breastfeeding in high-risk populations, particularly around having good informed choice and having actual input from experts in this field around what's safe and what's not, rather than just going based on hearsay or what some medical professionals may have said, but who aren't experts in pediatrics and the developing fetus and pharmacology in general. Our hypoglycemia protocols have a very significant impact on breastfeeding rates in this population. And I think there's probably a lot of work, again, that we need to do around education for our postpartum nurses and our NICU nurses around interventions. And the impact of the sort of specialized and free prenatal education that we provide through our program is unclear for us at this point, because we launched our classes sort of just as we were wrapping up or finishing up our evaluation. So we don't know what the impact of that type of prenatal education will have on infant feeding practices, but having the prenatal education very specialized to high-risk populations so they know what to expect. And we speak about infant feeding goals in the context of separations, NICU admissions, multiples, low birth weight infants, or birthing parents who have complex medical situations that may require postpartum ICU admissions or things like that. So we can create very realistic and sort of tailored goals and provide that type of information to people so they can, again, feel informed. The impact of mental health concerns, again, for those with anxiety or sleep dependence is very significant. Something we learned in our bereavement population is that the typical approach to sort of trusting your body, trusting the physiology of milk production and lactogenesis, and trusting that is a really difficult type of language to use with people who have experienced bereavement in prior pregnancies. Great examples would be people who have had, multiple preterm births or losses from early dilation. This idea of trusting your body and believing that it will do what it needs to do is very difficult for individuals who have lost pregnancies and infants before. And so it's a very, very difficult bridge to cross in terms of formula introduction and just trusting that, milk will come in and babies can lose weight and then they'll regain it. That type of education we have to do is very tailored and very specific in our bereavement populations. But again, just to wrap up, the sort of key takeaway from our program and our formal evaluation of our first 2 years is that home-based postpartum support can increase breastfeeding rates, even in this population who face a lot of barriers and early formula introduction in their early days of their postpartum, and that it really supports sort of the impact that has, whether or not we're hitting sort of target numbers that feel appropriate from a public health perspective, or whether we can do better. We feel like there's probably a lot of room for improvement, and are looking forward to ways to incorporate that going forward. But that's it for me. Just want to say thank you again, and feel free to reach out if you have any questions. Otherwise, I think we'll have some question and discussion time after.
Thank you so much, Lauren. Columbus, that was amazing and very obviously a well-monitored quality improvement setup that you have going there for a very risky population that needs all the help that you're providing. So our next speaker, and I invite you not to forget to put your questions in the chat, because Margaret is moderating that and she will make sure that those questions get asked at the end. Welcome to our next guest, Natalie Gohl, and I'd like to just tell you a little about Natalie. Natalie is a stay-at-home parent of 3 growing children, a dog, and their new kitten living in Guelph, Ontario. She spends much of her time volunteering for La Leche League Canada, a national organization offering free, trained, peer breastfeeding support, education, and resources for communities across Canada. Natalie has been a La Leche League leader since 2015, helping support families on their breastfeeding, chest feeding journeys. Since March of 2021, Natalie has been the treasurer, leader, accreditation department liaison, and a director on the board for La Leche League Canada. She's also a great ally and member of the Breastfeeding Committee for Canada. This passion and work has allowed Natalie to support more families across Canada, collaborate with other breastfeeding organizations, advocate for better infant and maternal health supports in our country, and work to build stronger relationships between peer support organizations and our healthcare system. And Natalie's talk today is about milk circles, how peer support connects families, healthcare, and a healthier planet. So over to you, Natalie.
Thank you, Kathy. I am excited to be here and feel honored that I was invited to do this talk today. I've enjoyed working the last couple of years with the Breastfeeding Committee for Canada to put together National Breastfeeding Week activities. So today I'm going to talk about how peer support connects families, healthcare, and a healthier planet. And I hope that you find what I have to say helpful in your own communities. So, Lalechili Canada acknowledges that we live, work, and support families on the appropriated, unceded, and treaty lands of the Indigenous peoples across Turtle Island, also known as Canada. We recognize the First Nations, Inuit, and Métis peoples as the original caretakers of these lands and honor their deep knowledge, traditions, and parenting practices that have nurtured generations. We also acknowledge the ongoing impacts of colonization, systematic inequities, and barriers Indigenous families face in accessing culturally safe perinatal and breastfeeding support. Breastfeeding is often referred to in Indigenous cultures as milk medicine, has long been recognized for its deep connection to healing, community, and resilience. Indigenous knowledge holds invaluable wisdom on infant feeding, traditional parenting, and the sacred role of milk in nurturing both body and spirit. We are committed to listening, learning, and amplifying Indigenous voices in lactation support while actively working toward reconciliation. We encourage all of our leaders to reflect on the land they call home, learn from Indigenous teachings, and support the work of the Indigenous birth and breastfeeding advocates. Together, we honor the past, engage in the present, and work toward a future where all families are supported with dignity and respect. So with that being said, today I am speaking to you from the traditional lands of the Haudenosaunee people, the Mississaugas of the Credit First Nations, Anishinaabe, and Attawandaron peoples. Okay, so a little bit about me, and a little bit of this might be echoing what Kathy said in the introduction. But I am Natalie Gohl. My pronouns are she and her. I'm a feminist, wife, and stay-at-home parent to a busy household of my 3 kiddos. They are 12, 10, and 8. We have a 4-year-old Great Dane named Hershey and an 11-week-old kitten named Kiwi. Both are currently sleeping, but Kiwi will likely wake up and find his way up here somewhere near my face at some point during this presentation. In addition to my home life, I have been a La Leche League leader since I completed my accreditation in 2015. I support families in and around Guelph, Ontario through our free breastfeeding group meetings and one-on-one support. I've also sat on the working board of directors for La Leche League Canada since March of 2021. I serve as the treasurer and the board liaison to our leader accreditation department. My work has also on the board has also allowed me to better advocate for breastfeeding and peer support, with opportunities to sit on many committees and task forces at the international, national, and provincial levels. So today's objectives are to understand La Leche League Canada and what our organization does, to highlight how peer lactation support complements and extends professional health care, ensuring that families receive continuous, compassionate, and culturally responsive care, and to illustrate how integrating peer support into the healthcare system can reduce the strain on our medical and environmental resources and also empower families. So, who is La Leche League Canada? So we are a registered not-for-profit charity. We provide trained peer-to-peer support, breastfeeding support from pregnancy, postpartum, and beyond. We are part of a global organization, La Leche League International, which is supporting families in over 80 countries throughout the world. La Leche League Canada has been supporting families for over 60 years with peer support leaders from coast to coast and as far north as Rankin Inlet and Nunavut. Our goal of supporting parents in raising happy, healthy children in every Canadian province and territory is shared by our healthcare system. La Leche League Canada contributes to this common goal by building connections, sharing resources, and providing educational programs. There's no cost to receive support from a La Leche League leader, and all regular informal group meetings are free of charge. So how do we do this? So we aid in closing gaps in health and care between hospitals, community organizations, and families by providing information and educational opportunities to healthcare professionals. We advocate for informed care and teaching around the International Code of Marketing of Breast Milk Substitutes. We provide information to parents on the normal infant behavior and support their feeding goals, and much more. So to kind of demonstrate a little bit about why peer support is so important in the lactation community, I have a few stories to share with you, and these are all from families who have come to La Leche League looking for support. So the first one is from a grandfather who witnessed Teresa, a longtime La Leche League leader, supporting his own daughter. A former coworker asked me to help his daughter, who was having breastfeeding difficulties with her first baby. The hospital nurses and the lactation consultant she saw from public health had not been able to help. I went to visit them and we talked about what was going on, and I made some more suggestions and asked her what she thought might work. As we talked it through, she was able to get the baby latched and drinking well. It doesn't always work so quickly, but it did this time. Afterwards, my former coworker commented to me that I didn't tell her what to do. He was expecting something like feeding plans that she'd gotten from the nurses and the lactation consultant. I've always remembered that as one of the big differences between peer support and medical support. We don't diagnose. We don't tell people what to do, but we help people figure things out and find out what works for them and their babies. The next story is from a mother who attended my virtual meetings throughout the pandemic. So Martina says, it's been 3 years since I attended La Leche League, but the lessons learned during those early drop-ins have stuck with me throughout motherhood. One of the biggest lessons learned was that our society breeds isolation in early parenthood, but that doesn't have to be how I experienced motherhood. I prioritized those virtual drop-ins more than the essentials of showering. I cozied up with my baby, lukewarm tea, and the conversation. It allowed me to live in the moment and appreciate how precious these days were. Sharing the small triumphs gave me the gusto to make it through the tribulations. Having the security to ask difficult questions gave me the power to be the best version of myself to support my growing family. And the final story is also a parent from my own group, Kate, who has been coming and attending for about five years now. So Kate is a mother of two. She first attended meetings virtually with a newborn and continued coming through another pregnancy and the birth of her second child. 5 years later, she is still reaching out for support when she needs it. Kate also created her own community outside of La Leche League meetings with other parents that she met in the group, finding their own village within ours. So Kate shares that peer support in La Leche League Canada has helped me through my breastfeeding journey, giving me the knowledge and the tools to be successful. It helped me grow in my confidence in the choices I made. When family and friends would question why I was still nursing past the age of 2, the Leche League helped me normalize it and teach me to quiet those voices. When I'm going through a rough bout, not sure what to do, it is awesome knowing that I can go to them for questions. So these are just some of many stories that I think probably all peer supporters can have to share, and from the families that have sought out our help and support when they needed it. So how does La Leche League Canada prioritize breastfeeding? So on this slide, you see the some of the ideas around this year's theme from WABA. So prioritize breastfeeding. They want to inform, anchor, engage, and galvanize. So over the next few slides, I'm going to share how we at La Leche League Canada can help all of these things fall into place together. So first, the World Alliance for Breastfeeding Action aims to inform people about their role in creating supportive and sustainable environments for breastfeeding. So La Leche League Canada provides evidence-based information to families, healthcare professionals, and communities across Canada. Our leaders are trained to offer support for anything from thinking about breastfeeding to weaning and everything in between. We have around 175 information sheets that have all been updated within the last 4 years. We also have last year launched our newborn nursing video collection, which is a great little series of videos to share with new parents so that they can see what good latching looks like, and lots of different positions and techniques that they can use. We have a virtual library. We have a YouTube channel that we are slowly building up, talks with different people from all different aspects of the breastfeeding world. We offer classes and conferences, and we're always trying to provide the most accurate information possible. On this slide are QR codes to some of these resources for you to take a look at. So next, WABA recognizes that continuous breastfeeding support is a vital component to creating a sustainable environment. So La Leche League Canada provides the information that we've just had a look at, resources and connections that families need, while helping alleviate the strain on our healthcare system and our environment. Accessing peer, that would be my dog that just woke up. Sorry about that. Accessing peer support means that rather than needing to seek out a doctor for questions surrounding normal breastfeeding and infant behavior, families can turn to trained peer supporters for this. It creates space in our healthcare system for those in need. Trained peer support also allows families to make informed decisions around feeding choices for their family. This aids in reducing the use of infant formula and its impact on the environment. It also gives parents the knowledge that empowers them and helps them build confidence so that they can better advocate for themselves and their children. So engage. WABA believes that we can engage with individuals and organizations to enhance collaboration and support for breastfeeding. La Leche League Canada is continuously working at the local, provincial, and national levels with other organizations, from doctors and midwife offices to universities and the Breastfeeding Committee for Canada. These partnerships allow us to better educate and advocate for and support our own communities. Finally, we can galvanize actions on connecting breastfeeding support systems to contribute to a more sustainable environment. By building strong support between healthcare communities and families, we can work toward creating a system that works more effectively. Helping families meet their goals, as well as easing the burden on our healthcare system, can reduce our carbon footprint. Educating the community around predatory marketing of infant formula while providing community support for breastfeeding can greatly reduce the impact that formula production has on our energy, water, and fuel resources, creating a stronger planet for our future. And that brings us to the end. So I think in a moment it'll be opened up for questions. So we have collaboration between our healthcare systems and our families and our environment can all work together and be stronger for each other. Thank you.
Right. Thank you very much, Natalie Gohl. That was a really interesting over coverage of what the Leche League does and the importance of it in our communities. So at this point, I'd like to invite Margaret Sherritt to step into the breach and tell us how much time we've got looking at the questions and comments in the chat. Go ahead, Margaret.
Okay, thanks, Kathy. And thank you, everyone. Those were great presentations. There's just been a couple of one question that's popped up so far in the chat was about a trend within their community. And I think just asking maybe for some feedback that a trend they've seen that there's been formula prescriptions have been frequently written by doctors and sent forward kind of based on they're saying based on Jordan's principle, and they may have to, they're wondering, is there any suggestions of how they can address this trend that's been happening? And it's from this question, actually, Jolene. I don't know if we're able to unmute. Maybe Jolene, she can pop on and actually maybe fill us in about Jordan's principle first, because that's actually a new term. I haven't heard that before.
I will just change the settings and then people can unmute themselves. Just give me one moment.
Okay, thank you.
We have some time for some good discussions. So
yeah, we're well ahead of schedule. So
you should all have the ability to unmute now.
Thank you. So Jolene, are you still with us that you can pop on?
Yeah, can you hear me?
Yep.
Yeah.
Oh, yeah. Hi.
Okay.
Thank you for answering or attempting to answer or address my question.
So Jolene, what is Jordan's principle, first of all?
So I work in a community that's in a First Nation, and so Jordan's principle is a program to meet children's needs, and wouldn't be the best to speak on it, but we have a department here that helps to meet sometimes it's social needs for families, a lot of times it's medical needs or respite. And so in our community, how it was explained to me is a NIHB, so non-insured health benefits, will cover prescriptions for formula based on medical reasons. And so the medical reasons, it's a pretty tight criteria where it's it has to be like certain medications that a mom really can't breastfeed with, HIV, different things that then non-insured health benefits will approve that formula prescription. And so then families can receive their formula prescription at the pharmacy. What we're seeing is doctors writing formula prescriptions for social reasons, and then families take that prescription to the pharmacy. NIHB maybe doesn't approve it because it's not a true medical need, but then it goes to Jordan's principal, and Jordan's principal covers the formula. And there's part of me that understands that there's families that can't afford formula, but then there's another part of me where I have almost every single one of my clients saying, can I get a prescription for formula? And then they don't have to pay for formula. And so it's just been really difficult, and I don't know how to address it. One of my goals is to work at becoming a breastfeeding friendly health center. And I don't know if it's a policy that I can put in place to say that doctors only write prescriptions based on a medical need, but I'm not sure. Or if anybody has suggestions at all.
Yeah, and I think, Lauren?
I was just going to say, I experience the same thing with our population as well, and that I think it's coming from a place of like harm reduction attempts on the part of physicians to say, you know, if you're realistically not breastfeeding and you need formula, then me prescribing this for you is a way to sort of reduce the potential harm of you not being able to afford it, and or using sort of unsafe sources of formula for your children. And therefore, you know, this seems like a harm reduction technique for me to take on. But I think for those of us who, you know, are well acquainted with kind of breastfeeding best practices, or the philosophy behind BFI and baby friendly initiatives, is we know that this sort of free and prolific and constant provision of formula is actually a barrier to breastfeeding, right? And so somewhat for the same reasons that, you know, to achieve BFI status, you know, hospitals are not supposed to be accepting free formula and kind of prolifically advertising it and providing it and having it in all the rooms. I think this sort of falls into that same piece of just like, does this mean that it's so prolific and it's given out and it's offered all the time? What does that impact have on breastfeeding rates? And yeah, I think with a population that struggles financially, it's a really sort of ethically difficult piece to address. I certainly don't have answers to it, because I have been in the position of, like those family physicians, of feeling like, you know, I know you have very limited finances and no access to formula, and yet we have a baby that's not gaining, you know, things like that. So then I do provide formula. So it, you know, I've been in that position, and I think it's a really difficult thing to navigate. I'd be happy to hear if others have some thoughts too.
Yeah. So I have, thank you, Lauren. Gail McCrae has popped up her hand with some thoughts, and Jennifer Quinn. So I'll let you weigh in first.
Thank you. Interestingly, there is not a lot of financial support in Nova Scotia, where I am, for people to get lactation consultant support in the community, or oral assessments, or even oral revisions if that's deemed necessary. It can cost upwards of $1,000 or more. And so I guess I personally struggle with the formula prescription being covered, but then breastfeeding supports not being covered. And so I co-chair the BFI committee at the NWK with another clinical nurse specialist here. And we are developing an advocacy brief to petition the government to cover these services as well via MSI or provincial Medicare program. I don't know. I've heard that it's been attempted in the past, and there's something to do with billing codes and having it not be possible. But when we did a scan across the country, there are provinces that do offer coverage for some of these services. So that's the lens that we are taking on this. I don't know if that's helpful, or maybe if that's something that you would want to talk about, or a partner on with, or maybe have some ideas around. But I feel really disheartened about the prescriptions as well. There's always, I understand that there can be a place for formula for sure, but also people are not getting the support they need because of financial constraints for actual breast and chest feeding. And so we should be starting there, I think.
Okay, thank you. Okay, over to Jennifer. Jen Quinn.
Hi, I'm here. I just had to unmute myself. It's nice to be here today. My name is Jennifer Quinn. I'm a program coordinator with Breastfeeding Buddies, a peer support organization with a very specific catchment, though, similar to the La Leche Lead, but not at all on that scale. But I'm just thinking there's a few things that we've been able to do here. One is that we reluctantly took on the Pumps for Preemies program. And I know that there is funding for that around, and we don't give them just to preemie babies. But we do that through having a navigator. So we have a navigator that is specifically a woman and child's navigator. It's me. So I'm breastfeeding friendly and I'm breastfeeding advocate. And so before anything would happen around infant feeding or making that prescription or anything like that, they would see the navigator, and we would be skilled. The navigator is skilled at sort of sussing that out. And then the other how do you do that? Like that, I'm not exactly sure. But if you said that everybody who has a baby is seeing a navigator, we can maybe hide breastfeeding advocacy in there. Not that we shouldn't have to, but not that we should have to, but I think we do kind of have to. Secondly, we don't love pumping either, but we would prefer pumping over formula. And of course, it's not our choice, but if persons has the decision-making chattel in front of them to make that decision, usually we hope they're going to go to nursing. And the other thing that we found within our own health center is a very direct referral pathway. And so that service can almost be like immediate. And we consider it a privilege to work in a health center that will fund breastfeeding support. We just got permanent funding after 7 years, but that is really the piece. Like if the physician can get us there today where we can talk or make a phone call or something like that, then that can really, they kind of say, oh, go talk to them. They'll talk to you about infant feeding. And then the big one that I think causes the most outcomes for us is prenatal education, including hand expression. Wink, wink. But we have a prenatal class that we could deliver anywhere in Ontario. And, we're interested in doing so too. So we could partner, we could do that. It's vetted by Region of Waterloo Public Health. We know that people, when they attend hospital and they've had that class, the nurses know because they don't need to triage breastfeeding as much. At times they're coming with actual colostrum. And so if we can sort of mitigate the family getting to the physician to need a prescription for formula, maybe that's the way.
Okay, thank you, Jen. Okay, this has really ignited some conversations, and so I'm going to hand it now over to Kathy, whose hand went.
Oh, thank you. I just wanted, there's such a valuable contributions here, but I also wanted to remind everyone on the call that the same discussions, these same arguments seem to come full circle every generation in terms of the ethical piece of supporting families, no matter what their feeding decisions are in all their different circumstances. And when we look at World Health Organization literature, which is current today, and we look at the WABA website, you will find the same tools that have been regenerated, the same arguments that come back full circle, but there's excellent material there for us to help ourselves build our own confidence in having these discussions and making policies, but also to share with parents so that it helps them with their informed decision making. It really is difficult. But when we look to infant feeding in emergencies, the guidelines that are provided by World Health Organization, and we look at our safely fed guidelines, we can see that this conundrum is ongoing, but I would urge you to look to those resources as well. And I'll try and find them quickly and put them in the chat, but I want to give others a chance to talk as well. Thanks very much, Margaret.
Okay, thanks, Kathy. And Natalie, your hand was up next.
So I just wanted to the point Jolene said about them writing prescriptions for formula. Some of that I think for some healthcare professionals sometimes comes back to maybe not having the knowledge which is another area that trained support, if we have other support such as La Leche League, can help with that, because if we have people such as yourselves going into doctors' offices and things and saying, hey, there's programs from La Leche League Canada that you can take to help better support your patients, or to gain more experience, or even, even just something to hand out to the parents with information for peer support. Those are things that then start building those connections between healthcare and the rest of the community, and help us to get into doctors' offices and hospitals and things like that to be able to provide that support.
Okay. Thanks, Natalie. Now I'm going to hand it over. I think Kayla was next, and then Laura's in queue. Kayla, are you there still? Okay. Okay. Well, Kayla, she says she's okay. So Laura, I'm going to hand the floor over to you now.
I just saw in the comments something I wanted to correct as well. So I'm actually the president of the Canadian Lactation Consultants Association. I've been working on getting lactation support, IBCLC specifically, covered. It has been a journey that is not going anywhere very fast, but this is where, check out our website, look at what we've already done. Gail, I think you mentioned about somewhere in Ontario, like there is no coverage for a non-RN IBCLC. There is no codes for us. Okay. So usually what happens, in particular, I work at a community health center I am funded under the the chiropodists, the social workers, our dietitians. I'm paid out of that funding. Okay. We do have a few part-time, in Ottawa, there is a full-time and very new position up in Thunder Bay. So Lorena also mentioned, please make LC support covered by OHIP. There's one breastfeeding clinic here in Toronto that needs a physician referral. I think you're talking about the International Breastfeeding Center. That is not the only lactation support. Okay, so there is, in some situation, IBCLCs are working with pediatricians to provide that, full scope support, which is amazing. But again, like in the population I work with, most of them are undocumented. They don't have OHIP. Only baby has the OHIP. So, it's another layer of challenge. And then the other thing I wanted to mention is that, yes, like having an infant feeding lead is amazing. I actually wrote down Jennifer. I'd love to connect with you, Jennifer Quinn. Because yes, I had a ability to have a large donation of pumps. I do not give out those pumps unless I flange size those mums, because a pump that comes out of that box 99.9% of the time does not fit. And this is also my problem with in-hospital, support. We give pumps to, families with preemies and things. And I have reached out to the local hospital and they're like, it's okay, Amita trained us, and Amita only makes 2 sizes of flanges, or Medela trained us. And again, they have a bit of a blind spot with that. So I think that, definitely the CLC is working on, we need more support, not just, if you're not maybe a member of the CLCA, sharing our social media and things like that, coming to any of our talks. Some of them are available for non-members for a low fee. So anyway, I'll put my email in the chat, so you can reach out to me. I'd love to connect with some of you. Our community health center is also part of the BFIC community center, so we're excited to work toward that as well. But yes, it's definitely, we don't have a good across Canada support network, and there is definitely like big gaps, right? So it's definitely challenging.
Okay. Thanks, Laura. I'm just gonna go to a comment in the chat before there's a couple more in the queue. On writing prescriptions for formula in Alberta, anyone can access a limited supply of donor milk. It dispenses at pharmacies, and there is a processing fee. It would be amazing if this program could be expanded to other regions with milk banks, and also if it would be good in our system, covered it. It's designated for bridging while breastfeeding is supported to get it back on track, but I would seem not for a long-term supply. And that is amazing that they do that. That is. Okay. So now I hope I've kept everybody's name. Oh, okay. I think it's Gail that I had that was next.
I'm not sure if I'm the only Gail, but I did already speak.
Oh, okay. Sorry, Gail. Sorry.
That's okay.
Oh, it's like I'm having to think fast. Okay, Sarah is next.
Sego, Sarah Merkel Youngyats, Guntege, Nidibakgena. Hi everyone, my name is Sarah Merkel. I'm from Guntege, which is Tyendinaga Mohawk Territory. Just to jump in a little bit on the Jordan's principal commenting, I worked here. I've since retired, but I did work here in my home community for about 12 years as the IBCLC. I stepped down during COVID, and it's taken a few years to get somebody else here on track. We just recently are celebrating having a new IBCLC here in the community, and we are thrilled with that. Just to address specifically Jordan's principle as a little bit of background, that was actually brought about by a boy named Jordan Anderson. He died while awaiting care because the federal government and the provincial government were arguing over who needed to pay for that care. I would like to also offer that I know the intent behind the conversation about prescriptions being written for formula is important and valid questions. I think everyone would agree that formula being given to children is not often a decision that a parent takes lightly, especially even my home community here. We are not, in the middle of nowhere. We are between Toronto and Kingston, sort of smack dab between Toronto and Ottawa, really about 2 hours both directions. We don't have good water. We have recently had water systems installed, but our whole reserve does not yet have clean water. Formula is not a decision people take lightly. Access to services, especially during a period where we did not have a lactation consultant. And even to get people into town to see public health, there are an overwhelming list of reasons why anybody might need formula and might not need to be able to afford it. So I would just like to remind people of that as well. One of the things I'm currently working on is myself and Dr. Jody John out of Queens. She's somebody who is from this community as well. We're currently studying in this community how we can raise up our breastfeeding levels, how people can access services, what are the things that are preventing people from accessing services. And we've had some really interesting conversations with people. So I think when it comes down to it is, and not that judgment specifically was involved, babies do need to be fed. And I know we would all love to see those numbers increase. I think what we can spend some time focusing on is perhaps how do we go about doing that for everybody, across the board. And yeah, and I would like to hear some talk about that. I think all babies deserve to be breastfed. And certainly I think to find a way to get these babies on track and healthy without being judged in the meantime is a great place to start. Thank you for your ears today, ladies. Oh, and gentlemen, perhaps. I'm sorry.
And thank you, Sarah, for your, helping us with our awareness that, just down the highway, literally experiencing, water safety and impacting the potential health, right? And I totally agree that, as much it's something that we need to focus on for across the board, across Canada, right? Instead of kind of pockets, and if we could get at a more unified approach. And that's where, like, I'm not on my political soapbox, but in the States, lactation coverage is covered, right? And it's such a contrast, right? It's like, wow, the whole basics of foundation of health. And here we're as Kathy said, we're singing from that song sheet and cycling it again and again, right? We move ahead and then we step back and we move ahead, and it's definitely frustrating. So ears are open if anybody has any ideas about how we could kind of move it ahead as a more unified force. Okay, Emma, and you're going to help me. There was I'm just going to read a comment, random question from Montreal, Quebec. The information about Breastfeeding Week for this year is not available in French. Do you know when the information will be available in French? And thank you. And we are a very small volunteer committee on the National Breastfeeding Week Committee, and we're English speaking. So we would welcome a French speaking member to come alongside us so that we could do this and provide translation services. That would be beautiful. Thank you. So if anybody wants to step forward for next year with that, with any languages, please consider that opportunity. And I, at points, we have been able to have translation services, but sometimes it's time, and it's in a volunteer group, and sometimes it's the fiscal reality for us too. So,
may I chip in, please?
Yeah.
I just wanted to chip in at the right timing. A Breastfeeding Committee for Canada refers frequently when we have questions about French translation of resources to our Quebec sisters, the MAC organization, who have a wonderful set of resources, and of course Francophone is their language. So we would encourage you to go and have a look. When you go to the BCC website, you can opt for the French pages, and they link to MAC as well. So please just look on the BCC website for that French page. You can just switch it at the top right-hand corner, and you'll see those resources as well. Thank you. Sorry to interrupt.
Okay, thank you. Okay, the next.
Sorry, I've had my hand up for a bit. Would I be able to jump in?
Sorry, Nate. Yeah.
Yeah, so I wanted to say now and to Sarah for to recontextualizing the conversation. I think that's really important. I'm a public health dietitian in Nunavut, and we see high rates of formula use as well. And I just wanted to speak to Jolene that, I hear you, and it's so challenging. And I also encourage you to look into whether, your maternal and child health care is culturally safe if you're working with First Nations. are your best breastfeeding resources translated? Are they accessible? Are traditional feeding practices promoted in your care facility? Is there an elder for someone to speak to if they have questions that they are not comfortable talking to their healthcare professional with, or they're looking for traditional knowledge? Formula use and suspension has very deep roots in colonialism, and so we need to be thinking of that as part of this conversation, and that includes pieces like water security. So thank you so much, Sarah, for bringing that up, because it's huge in Nunavut as well. Major challenges with having safe access to water consistently. So I just wanted to bring that to the table as well. Nakomi, thank you.
Thank you.
Thank you, Nate. We have Selena Bell.
Hi, sorry, I'm not able to access the chat for some reason, but I could have just put it in the chat. But I just wanted to offer a thought as we consider how we want to move forward in supporting parents who often live in the margins. Part of that work is making sure more voices are at the table, especially women of color, Black women, Indigenous women, newcomers, gender diverse individuals as well. If our goal is to truly support like all families, we need to look at how our approach, our language, and our systems may unintentionally exclude them. We need to like adapt to make it easier for people from these marginalized communities to step into peer support roles, or even to be recognized as the important leaders that they are. I think it's kind of an important step to opening our eyes as a community that's predominantly white, but deeply committed to breastfeeding support. So by widening who is represented, but also widening the reach and relevance of the care that we provide. That was just my comment.
Okay, thank you, Selena, for that. It's good wisdom. Okay, Sarah, you've got your hand up.
Oh, my apologies. I think that was just me at my keyboard. So carry on.
Okay. Thanks, Sarah. Okay, just kind of a chat conversation, and I hope I'm not missing as I'm back and forth. Maya, thank you for the inspiring conversation so far. I'm curious if anyone has thoughts about the need for peer support outside of the La Lèche League, for example, peer support that groups that are run by the public health system and perhaps take place in libraries, community centers, or early childhood drop-in centers. To be clear, I think La Lèche League does a great job, and my mom was part of La Lèche League when I was a baby. And I know that some people feel more comfortable with publicly funded services or perhaps more culturally tailored groups. Would love to hear thoughts from anyone about this. And any comments? I think there's, when I read this, my thought is, there's always niches that fit different people, and it's great that we can have different kind of segues of different services depending on what that family feels that would support them. And that's why I think it's great to have different kind of opportunities present, right, with kind of almost sectors working together. There, as in like Waterloo Region, right? Breastfeeding Buddies is a forefront organization that has helped to lead kind of the development in different centers, and how it, like it is in Guelph, we breastfeed and La Lèche League, and often they've collaborated and worked together on so many different community events. I don't think it's work so much in isolation. It's just opportunities, right? What's going to fit for that family. Okay, I think we're almost running. Levine, you've got your hand up. Levine, are you there to unmute? And okay, Jen, I don't see Levine popping on, so I'm going to pop over to you.
Okay, just cut me off if they come back. I have a couple things. One is folks supporting Indigenous families. We are a part of the First Foods initiative coming out of University of Waterloo, which is, I guess, reintroducing food sovereignty for Indigenous families and communities. Of course, human milk feeding being one of those facets of food security and, food sovereignty. And that's where we are empowered. I was empowered to talk about the risks of not breastfeeding. So I find my own way to sneak in those risks of not breastfeeding, but really we want to honor all families, and we don't go forward and speak of the risks of not breastfeeding. But in the case of Indigenous communities, there are many, many cultural risks of not breastfeeding, that they're not connecting to their elders, they're not connecting to the ancestors. And I don't even know enough about this really to be speaking here. It's just because you happen to be captive audience. And so if you want to take a look at the First Foods, I could warm hand you in. We could work together some way on that. And then the other thing about the peer support and how do we do it is, like, Breastfeeding Buddies has a turnkey solution. It would cost a little bit of money, not a lot, and we would design and develop and even give you our program resources and train you to use the safe languages that we use. We have most of our stuff is translated into about 13 different languages. The biggest example I use is with a newcomer family, they're not going to want a hand expression kit with a picture of a breast on it, right? It has to be sort of a cartoon or just a hand or something like that, because they just simply are not taking that home. And these are small wins that we can do right off the bat. And then in our area, region of Waterloo, the attachment rates are very good, very good. Lots of people attach their babies, most in fact. Latch their babies, but it's that 2 to 3 week piece where things aren't going great. And then where is the support going? So if they can see me teach the prenatal class, me do the bedside support at the hospital, and then they can phone me and maybe come and see me in my office, do a breastfeeding check-in with me, that continuity of care is amazing. Yeah. And we know if we've received any sort of social, psychological care ourselves, unpacking it again, each time we go to see somebody, giving it new, knowing the story, all of that is exhausting. And if you could get a prescription for formula, you might just choose that. So call Breastfeeding Buddies and we will, we will give you a turnkey solution if you like.
Okay. Thanks, Jen. I'm just going to, just in the sake of time, we still have some comments, but I'm really looking at our clock. And so what I'm going to suggest is I'm just going to do a quick wrap up. And then if you want to stay on, Natalie and Hillary, there's some comments. I can see your hands have gone up. So I just want to be respectful of the time. So please stay on after the conclusion. So I just want to thank everybody for attending today. This has really been a fascinating discussion, fascinating presentations. Both of you shared powerful and wise words today. Systems that sustain, wise words about your systems that sustain were so beautifully illustrated by both speakers. Thank you, Lauren, for demonstrating how collaboration across health sectors can bring together different strengths and wisdom for optimal care. And your data actually was striking, and how you're using your data to start to unpack kind of the next steps in your programs, such an example of starting prenatal education. Thank you, Natalie, for showing how peer support can work together with medical models to improve long-term health trajectories for those within your circle of care. And it truly speaks to that each and every family needs their cheerleaders, needs their enablers. And, you know, everybody on this call has such an important role in being the cheerleader and enablers. So thank you for all you do for all the families. that you work with. And I have a saying that together is always better. And isn't this so evident in the conversation, the presentations today, that, you know, in isolation, we can only do a little, but when we form together, we can do a whole lot more. So thank you. Okay, so if anybody needs to pop off, that's fine. And thank you once again for attending. The certificates will be coming in your email with an evaluation, so please take 2 minutes to complete that. That's really helpful in working towards next year. And I'm going to circle back because I had sorry, I've got 3 sheets going with all different names. So Natalie and Hillary. I think Hillary was first and then Natalie. Hillary, are you still on?
Yes.
Okay.
So I registered in my role with Citizens for the Code, but like Natalie, I'm a La Leche League leader, and La Leche League Canada does have resources in languages other than French or English. Ligue La Leche, of course, is the Francophone organization in this country, but for those working with people who may not speak the languages available on either of those websites, the homepage of La Leche League International's website can help people see if there's La Leche League in their home country. And in this era of online meetings, people may be able to connect with the La Leche League meeting in their home country in a language in which they are comfortable.
Okay. Okay. Good information, Hillary. Thank you. Natalie, I'm going to pop back to you.
Yeah, just to add a little bit to what Hillary just said, we also have several virtual groups in Canada offered by Canadian leaders for different populations. We have a Ukrainian group, Portuguese, Arabic, Mandarin. We have a BIPOC group. We have a group for the LGBT community that are offered to anyone in Canada. So you can go onto our meetings calendar and find those on our website. And I also wanted to point out about publicly funded. I'm not sure. I guess publicly funded. I just wanted to clarify, Maya, about that question. And people feeling more comfortable with publicly funded services. Is that because they feel they're more reliable? And I'm not understanding that. We're a not-for-profit, but we have a very intense training process for our leaders. So I'm not sure just about that. I'm not sure if you're still here, Maya, to clarify. Might be gone. So we are a not-for-profit, which means everything we do is by money that has been raised by our leaders and supporters. But we are also, the training program that our leaders go through is an intensive program with certain requirements for how long you've breastfed your own children, that you've attended our meetings, and it's also an international program. So the training that you will get with a La Leche League leader anywhere you go in the world will be the same training. So whether you attend our meeting or somewhere else in the world, or move and seek services wherever you move to, training is all the same, with the exception of laws or things like that in specific countries. So that is kind of just a very quick overview of our training. And I think that sometimes with other breastfeeding support programs, there's many that are very, very good, such as Breastfeeding Buddies, La Leche League. sometimes if you're backing those programs, it's good to look into how their training process goes and what the requirements are for it, because they're not all the same. So being aware of what's available in your community and what the training is behind it. Something with peer support is making sure that people that are supporting have their own breastfeeding experiences and have some training behind it to properly properly communicate and support people in their own communities.
Okay, thanks, Natalie, for sharing that. Okay, so is there any other comments? Because we're well past our time now. And this has been, I think it just shows how there's a lot of passionate people and there's so much that we could, if we could bring it all together, right? It would be magic with all the passion in this group.
Margaret, can we just remind everyone that's still on the call that we've got one more session next week. We also have a round table coming up, and we would love you please to tag us on your social media posts. So the upcoming event, the BFI Roundtable, November the 5th. And I'll just leave it there for a second so you can look at that barcode if you're interested. That's going to be fascinating with learnings from Australia and the Australian Breastfeeding Association. And Emma, I don't know if you want to quickly chip in.
Sure, I'm happy to. I know I don't want to take up too much time, but yes, on November 5th from 12 to 1:30, the BCC is hosting a BFI roundtable, and we're fortunate enough to be hearing from Karen Graham, who is speaking from Interior Health in British Columbia. So the Breastfeeding Systems Change Project. So you can scan the QR code there, or it'll be up on BCC social media or the website to register. So we'd love to see you there.
Okay, thank you. Okay.
Thank you, Margaret. I'm sorry I chipped in there, but I desperately want everyone to tag us social media.
Oh, thank you. Thank you. I should have, thank you. Okay. Okay. Well, thank you for attending today, and we'll see on Tuesday.
Okay. Thank you, everyone.